the new AASLD guidelines for non-alcoholic fatty liver disease has come, which is a big emerging disease, which is possibly bigger than the pandemic that has almost close to seeing its end. But this is the onset of a new pandemic. So this is the outline of my discussion. So we will discuss the published guidelines. These are not my personal views, and I'm not vouching in favor or against these recommendations, but this is what the scientific evidence say. So how do we define non-alcoholic fatty liver disease? So a normal liver is expected to have less than 5% of fat in the hepatocytes. If it is more than 5%, it is theoretically called as non-alcoholic fatty liver. If the person takes less alcohol, that is less than 20 grams per day for females and less than 30 grams per day for males. However, we hardly are able to detect such little fat because the ultrasound, which is the modality which is commonly used to detect a fatty liver, can detect only when the liver has more than 33% of fat. So when there is a macrovesicular steatosis, we call it as inflammation, and when it as a non-alcoholic fatty liver, and when it is coupled with injury like ballooning of the cells on histology, we use the terminology NASH. NASH by definition is a diagnosis only to be made based on biopsy. However, when we loosely apply this term in patients who have fatty liver and have a rise in ALT level, though we should keep in mind that a normal liver function test doesn't rule out inflammation and ballooning inside the liver. So the update on the epidemiology and the guideline is that the prevalence of fatty liver is close to 25 to 30% in the general population. We understand that we don't screen the general population to get such data. There is data from this colon cancer screening patients. This is the data from Europe, where it is found that 14% of patients undergoing colon cancer screening have non-alcoholic fatty liver disease. And it is expected that the rate of hepatic decompensation, the need for development of models to predict decompensations are on the way. The progression to development of cirrhosis, HCC, due to NASH is expected to increase by 2 to 3-fold by the year 2030. And it is expected that the number of patients who will be diagnosed with F2, F3 fibrosis will be doubled in the next 10 years. So the natural history of non-alcoholic fatty liver disease, we all know that fibrosis is an independent predictor of which disease of NAFL will progress to cirrhosis. The new guidelines have introduced a term called at-risk NASH. So these are patients who have non-alcoholic steatohepatitis with an F2 fibrosis, which is diagnosed on biopsy or by 2 non-invasive tests. These patients have been found to have a higher liver-related mortality and morbidity. We all understand that the natural history of the disease is influenced by lifestyle changes, and therefore it is important that people who are at risk NASH are regularly screened for the development of cirrhosis. And those patients who have developed cirrhosis should have a biannual screening for HCC with an ultrasound and an alpha-fetoprotein. In patients who are compensated, can decompensate at a range ranging from 3 to 20% per year. So when we talk about the disease outcome in patients with fatty liver, we should understand that the most common cause of death in these patients is not because of liver. It is because of a cardiovascular disease, mostly a coronary artery event. This is followed by the death due to a non-hepatic malignancy. And finally, it is related to a liver-related cause. So when we talk about liver-related cause, the more the fibrosis, the stronger is the association with development of cirrhosis and liver-related mortality. So this table below nicely shows the all-cause mortality. If the fibrosis is low, the all-cause mortality is around 0.2 per 100 years. If there is bridging fibrosis, it slowly increases to 0.89. If it's cirrhosis, it increases to 1.79. The moment there is hepatic decompensation, the risk of all-cause mortality increases to a hazard ratio of 6.8. However, now there's a new terminology which is very much in use, which is called recompensation, or even some cases we see a regression of fibrosis. So if there's a regression of cirrhosis, this is associated with a 6-fold reduction in liver-related events. So what are the pathogenic drivers which causes NAFL? And these pathogenic drivers are the ones which, when we can target, are actually our therapeutic targets. It is presumed that it usually starts with an imbalance between the energy intake and the energy expenditure. The excess energy intake comes from high intake of dietary fructose, glucose, and sucrose, which overshoots the capacity of the adipose tissue to take care of it. And this also is coupled with a de novo lipogenesis leading to accumulation of free fatty acid, which cause lipotoxic lipids, leading to oxidative stress, ER stress, and also leads to inflammation, leading to progression to fibrosis and a hepatocellular carcinoma. The major modifying factors is that there is a role of genetic polymorphism, like the genes like PNPLA2 and TM6SF2, which are found in Indian population as well as Asians, have an increased risk of progression to fibrosis as well as ACC. So the therapeutic targets could be, we can modulate the food intake, we can devise methods to increase energy disposal by exercise, diet, we can improve the adipocyte insulin sensitivity, and also try to target the de novo lipogenesis, and if possible, see if we can increase the oxidative metabolism and decrease the inflammation and fibrosis. There is a significant role of comorbidities in patients with NASH. We hardly see a patient of NAFL who do not have an additional comorbidities. Obesity is the most common. Many are obese, many are overweight. So obesity is being reported to be associated both in the pathogenesis and progression. The visceral fat, so a fatty liver patient who has more visceral fat has more cardiovascular risk. And patients who have this stressed adipose tissue, that is adipose tissue which is not healthy, leads to insulin resistance. Coming to diabetes, majority of the patients will have associated diabetes. Patients who are diabetes and have NAFL has an increased risk of progression to ACC. The prevalence of NAFL in type 2 diabetes varies between 30 to 70%, but it is a bidirectional relationship. In fact, patients with NAFL has 2 to 5 times increase in diabetes, and that itself is a talk by itself, a bidirectional association with this. Whether a glycemic control is related to the progression of NAFL has not yet been established. Coming to hypertension, there are significantly more number of hypertension seen in patients with NAFL, which increases in patients with NASH-related cirrhosis. These patients will have dyslipidemia. So it is seen that if this patient has a NASH resolution, which is usually coupled with a loss of weight and exercise, they lead to improved HDL and triglyceride levels. However, we should keep in mind that the patients of NASH who develop cirrhosis have still a high risk of coronary artery disease. If moderate intensity exercise, statins, and fibrates are to be given, these are safe in patients with NAFL and patients with compensated cirrhosis. Many of these patients say, I don't feel fresh in the morning. This is because they don't have a good night's sleep. This is because of obstructive sleep apnea. Obstructive sleep apnea again has been reported to be associated with advanced NASH histology and fibrosis. However, the strongest problem that we are facing now is cardiovascular and chronic kidney disease. There is a significant association of atherosclerotic heart disease, heart failure, and particularly atrial fibrillation in patients who have NAFL. This is a finding which is most commonly missed. The incidence of fibrosis along all stages of similar level of cardiac events. And there is a twofold increase in the prevalence of chronic kidney disease. We don't know whether this is just because of the development of NAFL or because many of these patients has type 2 diabetes, which is leading to chronic kidney disease. So just keep in mind that when you are treating a patient of NAFL, you are not only treating the liver, you need to take care of all these comorbidities. Look for signs of insulin resistance always in these patients when you see them in the day-to-day clinic. So how do we approach a patient with NAFL? When we suspect a patient of non-alcoholic fatty liver disease based on imaging, always try to rule out the mimics. There can be some drugs like amiodarone, tamoxifen, or methotrexate, which can cause microvesicular steatosis and fatty liver. Similarly, there are some genetic problems which are pretty rare, but that can also lead to non-alcoholic fatty liver disease. Always remember to look out for hidden alcohol use, which the patients may not report. So we look for all other metabolic comorbidities that we have just now mentioned: diabetes, hypertension, dyslipidemia, obesity. And we should keep in mind that alcohol is a strong confounder of fibrosis. Patients of NAFL have to be screened for hypothyroidism. And there has been studies which says that NAFL is more in patients with hypogonadism, and testosterone replacement has been tried in few selected patients for treatment of NAFL. As I said, we look for signs of insulin resistance, mostly on the back of the neck, and we can see in the knuckles. These are things which we commonly miss. And also, if there are signs of advanced liver disease like palmaerythema, gynecomastia, or spider nevi. So based on this, we order some laboratory tests, which are a very simple test, which we do in our day-to-day practice. But never forget to look out for the viral markers, because some patients may have NAFL coupled with another viral etiology. The next big question is, since this is such a big disease, what does the guidelines recommend? Does it recommend to screen everybody? So the general population-based screening for NAFL as of now is not advised because it is not found to be cost-effective. What they recommend is targeted screening, that is people with diabetes, obesity with metabolic syndrome, patients with a family history of cirrhosis or concurrent alcohol use are the ones who should be screened for NAFL. The primary assessment can be done with a non-invasive test like a FIB-4, and in patients who have more than 2 metabolic risk factors, who have diabetes or a pre-diabetic, needs an assessment every 1 to 2 years. And then there are secondary assessment which can be done by vibration control elastography, AR5, or a magnetic resonance imaging. This is based on what is available on the local thing. Particularly, keep in mind the diabetic patient, obese patient, alcohol moderate use, and first-degree relatives should not be missed to be screened. Coming to lean NAFL, there will be a patient population who are not very obese or look thin also, and this is what is called the Asian paradox. These patients can still have fatty liver. It is as high as 19% in Asia and around 4% in the United States. And as I said, it is mostly associated with these 2 gene mutations. And we should keep in mind that diagnosis of patients with NAFL in absence of obesity is challenging because these people don't realize they have it. And also, when you tell them to lose weight, they just get scared because they're already lean. But however, dietary modifications and exercise in this group may still be beneficial even in the lows lose weight. So when you suspect fatty liver, this is what the guidelines say. You can diagnose it in the primary care center by doing a FIB score. If the FIB score is high, you can try to do additional test, second level assessment with a fibrosis assessment. If it is normal, we can repeat it 1 to 2 years for if there are high risks. If there are no high risks, we repeat it every 3 years. If the fibrosis level is high, then we refer to a hepatology clinic who can reassess these patients and decide whether a liver biopsy is required or not. And based on what stage of fibrosis is there, the treatment can be customized. Coming to the non-invasive test, the guideline says Ultrasound is not recommended as a tool to diagnose steatosis because it has low sensitivity. However, in real life scenario, this is the test which brings the patient to the doctor. CAP score is one which can tell us about the degree of steatosis, and we can also use an MR-PDFF, or if the FIB score is more than 1.3, we can use any of the non-invasive test. It could be a FibroScan, it can be a FibroTouch, it can be an ARFI, it can be a MRI if the person is undergoing CT for any other reason. It could be an LAI, it can be MR spectro, PDF, or elastography. Whatever modality is available, it is important that is used to diagnose these patients. The role of liver biopsy is important in few cases because it can differentiate between simple steatosis to ballooning, to inflammation, to interface hepatitis, to bridging fibrosis, to cirrhosis. These are mostly done in patients where the non-invasive tests are inconclusive or where we are thinking of an alternative diagnosis. My last few slides is concentrating on the treatment, what the guidelines say. They say it must be a multidisciplinary care. The primary care provider are the ones who possibly diagnosed. It should be weight management. It should be a gastro and hepatologist. And there is a significant role of a health psychologist because it is presumed that fatty liver is related to eating and diet control. And most of these patients have a low level of threshold to eat, and they are depressed and they keep on going through a vicious cycle. So weight loss, it is recommended at least more than 10% of weight loss for fibrosis resolution, around 7% for NASH resolution, around 5% for ballooning to go, and 3% for steatosis. What is important is the sustained weight loss. There should not be up and down. And that is where you need somebody to motivate the patients to lose weight. It can be aerobic activity, it can be resistance exercise. Coming to diet, we should understand not one diet fits all. Some people recommend a Mediterranean diet because it is being proven to have an additional cardiovascular benefit. But whether somebody is taking a low carb or low calorie or doing intermittent fasting, none of them has been found to be superior to another. However, fructose restriction, prevention of soft drinks is very important, and coffee, 3 cups of coffee, irrespective of caffeine content, has been shown to improve the level of fibrosis and reduction of the fat. This exercise, most of these patients, when you say, they will say, I can't do it, but we should recommend 5 times a week of at least 150 minutes of exercise. And the optimal duration, remember, we should not be too pushy. This is what the guideline says now, that it optimize it according to the personal needs. They must be encouraged to exercise as much as possible. And some people who can't walk, jog, can do resistance exercise. The last few slides are on drugs. This is very old data. The PREVENT trial, vitamin E is still mentioned in the guidelines. It is associated with a lower rate of decompensation, but vitamin E has never shown to improve fibrosis. It has no cardiac benefit. Pioglitazone in patients with NASH and diabetes have been shown to help, but the potential side effect is a paradoxical weight gain, which can again worsen NAFL. None of these 2 drugs are approved for NAFL. Then there's a lot of discussion on vitamin E versus tocotrienol. There is no data to prove the superiority, but a lower dose may benefit than vitamin E. Coming to the newer drugs that people are using, the liraglutide is a drug which is US FDA approved for type 2 diabetes with obesity. Because these patients have diabetes and obesity, they can lose weight, which translates into improving steatosis, but again, no benefit on fibrosis. Coming to semaglutide, which is a drug which is very much in use now, either the injectable one, again approved for diabetes and obesity, shown to improve steatosis with no proven benefit of NASH on fibrosis. But again, these are very early data. So phase 3 trials on NASH-related fibrosis are ongoing. This may need 3-4 years before we get the actual data. Then Tirzepatide is again another drug approved for diabetes with or without obesity. It is shown that the patients with non-diabetics also, there's a significant amount of weight loss and the liver fat resolution is quite high, suggesting that this could have a potential benefit on NASH, though trials have not been designed for this particular purpose. People are using a lot of SGLT2 inhibitors like EMPA and dapagliflozin for patients with diabetes, which are the approved indications are in diabetic patients with cardiovascular disease and chronic kidney disease. These drugs also can induce some weight loss, and this could translate to reduction on steatosis on imaging. But again, there has been no effect on fibrosis. And a word of caution is the presence of UTI in these patients, so they should be very careful. So what not to use? Metformin is an absolute no for NAFL. But if we are using metformin for diabetes, if we give it in patients with cirrhosis, it can be associated with improved survival, no UDCA. Statins, if it is required from a cardiovascular point of view, can be given. In decompensated cirrhosis, we should avoid. There is no role of silymarin. Coming to role of bariatric surgery, the guideline says that the bariatric surgery should be considered as a therapeutic option if they require a surgery from the metabolic weight loss point of view. Resolution of NASH has been seen 80% at 1 year following and 5% at year 5, 80% at 1 and 5 years. That is a sustained benefit with bariatric surgery. Restrictive surgeries are equally useful. Patients who are compensated cirrhosis, we should not consider bariatric surgery as a primary therapy, but in selected cases, because of bariatric indication, it can be done. But in patients who have decompensated cirrhosis or have a clinically significant portal hypertension, it is an absolute contraindication as it is associated with post-op mortality. So, in conclusion, the newer additions is the definition includes an at-risk patients with NASH. There is no population screening, but patients who are at high risk, particularly diabetic, obese, should be screened. How to screen is by FIB4. The care has been divided into primary care and secondary care. The secondary point of care includes a fibrosis assessment and a fibrosis and a CAP score assessment. The guideline recommends absolutely zero alcohol for patients with F2 fibrosis. Fibrosis screening should be done in first degree relative on patient with NASH cirrhosis. And the guideline supports actually off-label use of drugs like semaglutide, vitamin E, or pioglitazone in non-cirrhotic NASH, each tailored to their appropriate clinical scenarios, but none of these drugs are FDA approved. With this, I would hand over to Sunil because you have an exciting transplant related talk awaiting after this. Thank you so much.